retract the muscle or turn the globe so that you'll be able to reach it. Otherwise, it's very, very difficult. In spite of doing all of this, sometimes you may not be able to reach the globe. And those eyes would already have a very poor prognosis. Counseling is key in these cases. And we all know most of these cases will come with multiple attenders. They'll come with so many people around. So counseling has to be very, very detailed and multiple times over, and still after surgery they will come and ask, will we get vision? We have all seen those situations. So you just have to keep reiterating. Consents have to be very, very clear. Documentation has to be very clear, and we'll have a talk on that as well. But yes, from your side, whatever you can do in surgery. We'll move to our next talk.
So next will be Dr. Sumeet Lahane, needs no introduction. He'll be taking us to an approach to orbital trauma and fractures. It's important to understand that injuries are not only focal. Many times it involves cornea, sclera, could be an orbital fracture. And how do you approach such a case is what he'll be taking us through. So over to you, Sumeet.
Thank you, Gairik. Thank you, Sharon ma'am and AIOC for including me in this IC. I will be talking about an approach to the orbital trauma, and ma'am told me to keep it strictly case-wise. The whole intention of the presentation is that by the end of presentation you should understand what you should not miss when you see a case of orbital trauma. So I started searching for the incidence, but there are very rare studies which talk about the orbital fracture incidence as such. The incidence of the ocular trauma is around 4 to 5%. And especially in the RTAs, the incidence of the orbital fracture is maximum compared to the anterior segment trauma. Now, orbit anatomy all of us know, but these three things are very important as a structural point of view when we are talking about the orbital traumas: is orbital rim, orbital wall and orbital apex. So very first you need to understand the mechanism. The very old theory is the indirect injury or the buckling theory, where there is a blunt trauma on your orbital rim. Nothing happens to the rim because the rim is very steady and strong, but the buckling happens to the floor, which is one of the weak portion of your orbital floor. Second is a hydraulic or the retropulsion therapy, again which says that there is a blunt trauma and there is a displacement of the orbital contents which suddenly try to pop out through the weakest portion of the orbital wall, which is orbital floor as per the theory. But all of us know that the weakest portion is the medial wall, lamina papyracea, and it should break away. But it does not happen, and the explanation for that is having a ethmoid bone which buttresses the lamina papyracea, and it prevents for being the most common site of the fracture with the blunt trauma, and the floor becomes the most common site of the fracture. Now let's go case wise. Now you see a 50-year-old male, most commonly we see in our residency days a raccoon eyes kind of a picture, and when we see this looks very ugly and it becomes very difficult to understand what to do imaging and start explaining the guarded prognosis to the patient. The most important is you take a vision and the pupillary reaction and you advise a CT scan. And you will come to know that everything is only preseptal, there is no orbital involvement, no bony involvement, and the prognosis is very good only with the conservative RX. Now one point I would like to highlight here is when you advise a CT scan, do write that what are you advising it for. It's better that you mention everything every time, even if your radiologist is the same. It's 1 millimeter cuts, axial plus coronal sections, with sagittal reconstruction, with contrast, especially in cases of trauma, and please mention Hounsfield unit in case of mass, foreign body or whatever, if they find incidentally or you are suspecting, and do write indication that what do you want to look for. If you see RAPD, then do write that you are looking for optic nerve avulsion in this imaging. Now this is another case, 20-year-old male came with the history of reckless bike accident. We told him to get the imaging done and get admitted. Patient was not so willing. Patient went home. Again, I got a call in the night that there is one patient came with the trauma. I said so many traumas in a day. Then I realized it's the same patient came with the increased proptosis. Now the same patient you see who had a trauma in the morning comes back in the evening with the increased proptosis. What could be the cause? Can anyone think about it? Trauma happened and after 12 hours, suddenly there is increase in the proptosis. So somehow we could see the pupil is getting dilated, retina still seems okay, and when we do the imaging, here is the answer. So whenever there is a trauma, there could be fracture, and now the orbit and the sinuses are connected to each other. So forceful coughing, sneezing, everything can suddenly have a gush of air inside the orbit, and your proptosis suddenly can increase. And that might cause orbital compression syndrome altogether. And this is orbital emphysema. This is very old classification. Still we follow the same classification, and accordingly the management depends on the how severe is your orbital emphysemas. Most common treatment what we do is lateral canthotomy and cantholysis, which is the easiest way. You can do bedside as well. Sometimes orbital decompression is needed. In between treatment is needle aspiration. Now needle aspiration becomes very difficult to see a imaging, and then you see that where do you want to insert your needle and find the air. So easier way to do that is you take a syringe, fill with the normal saline, remove the piston behind, and let your needle, hypodermic needle, pass as per your guidance of imaging. And once you start seeing the air bubbles, that is the point where you can have your orbital emphysema and the aspiration can be done. This is just to highlight that whatever is the case, the vision, documentation, pupillary reaction is the must, howsoever bad is the patient. Now this is 12-year-old boy with the history of eye pain. Sorry for the excessive cropping. He was complaining of eye pain since last 15 to 20 days. Parents ignored, saying that he don't want to study, so he is complaining. Finally they went to pediatrician. Pediatrician sent to ophthalmologist. On evaluation we realized that there is deficit in the elevation in the left eye. Of course we went ahead with the imaging, and this is what it is. It's a white blowout fracture. It is a white blowout fracture, which is very common in the young individual, and they may not come with the pictures of a red color, congestion, diplopia, because child may not complain of all this. Now why this trapdoor kind of a fracture happens? Now all this mechanism the same what we discussed in our first slide. One thing that you need to understand, this is just because the walls are much elastic compared to the elderly individual, and the wall recoils faster than the content, and it does not allow the contents to go back. So once you are into the sinus, you are into the sinus and the doors are closed. That's why patient comes with the only deficit, and there are no other symptoms patient may present with. Now this is from my friend Dr. Adit Gupta. This is just to highlight the same point. Again a young patient complains of eye pain, diplopia. Again presentation is delayed, and when you see the adduction is limited. The adduction is limited, and vitally patient has a pulse of only 40 beats per minute, which is again a little not so common in a younger individual. So when we do imaging, we see there is a medial wall fracture. There is medial wall fracture. And this again to highlight the importance of the force duction test. Before planning your surgery, or at least on the table, or patient is cooperative in your office, you should do force duction test to know the restriction even before you plan your imaging. Now post surgery patient improved. This medial wall fractures are again to highlight there are two important things whenever you suspect a medial wall fracture. Always measure the intercanthal distance. All of us know intercanthal distance more than 35 millimeter is nothing but telecanthus. Why does the telecanthus happen? It happens because in any medial wall trauma, there are high chances of disruption of the medial canthal tendon. And once the medial canthal tendon is destroyed, the intercanthal distance will increase. And then you have a picture like this. This is very important when you want to do a repair of the any medial wall fracture. First thing. Second thing is you need to look for imaging very carefully, because this patient will have a damage to the nasolacrimal duct. So even if you correct the fracture and everything, patient will be keep coming to you with the complaint of watering. So later in the time they will need a DCR surgery along with the intubation, which will last maybe for 3 to 4 months altogether, and not like a routine DCR intubation. Now taking ahead from this point, one more case where a 40-year-old male present with the history of trauma, eye pain and the watering. And once you do imaging, you see there is a orbital roof fracture. There is orbital roof fracture. We take a call on this, medial wall looks fine, patient got operated, rest of the conservative management, everything well, but keep coming to us with the persistent watering. Now, there is no nasolacrimal damage, still patient has watering. Can anyone see what is the cause here for the watering? So, many of you may have seen these cases. If not, then what happens? This is very well reported. There is cerebrospinal fluid which leaks as a tears, and this is nothing but oculoria. Like your CSF rhinorrhea, this is oculoria where the watering happens, and this is basically a CSF. Patient may complain with the complaints of giddiness along with the watering. And the diagnostics, all of you know, do a diagnostic beta-2 transferrin fixation, which will come ahead with the diagnosis that what are you looking at is a CSF leak, nothing else. Many of the times managed conservatively. So this is to summarize everything in the 2 slides, that you do a clinical evaluation, your anophthalmos, trismus, orthoptia, FDT, sensation, and the CT scan comes in the end. So to evaluate everything, if you see carefully, everything can be done. Everything can be done in your office setting. The point is, when you see a case of orbital trauma, the documentation, consent, everything is important. But like your LASIK patient, like your other premium IL patient, you need to give a more chair time. These cases also need a more chair time for your own evaluation, more than talking to a patient, so that you don't miss anything, and the most of the diagnosis is done on your office itself. These are indication of repair. Don't go ahead with all the indications. Only remember 2 things: patient presenting with the bradycardia, patient coming with the bradycardia, and the white-eyed fracture need a urgent repair. Rest also need a urgent repair, but they can be till the patient is fit between 2 to 3 weeks. But having a oculocardiac reflex is a urgent indication to repair your orbital fractures. Just to conclude, that it's a multi-system trauma. You may not get a isolated orbital fracture always, so you need to involve a other specialist in this. Adequate use of imaging, clinical evaluation, but do mention that what are you doing imaging for. You need to expect something from the imaging, proper consent, explanation to the patient and the relatives. Generally, we want only one relative with one patient, but if such a case of orbital trauma comes, do allow all the relatives to sit with you and explain them at one go. Otherwise, every time a new relative will come and keep asking you the same question, it will be difficult for you to explain them same thing again and again. And documentation is a must pre and post operatively, whether you operate the patient or you don't operate the patient. Thank you all for patient listening.
Thank you very much, Dr. Sumeet. That was wonderful.